Good day. I'm doing a video recording of a session, in-service session that I've done for the last few years at work about self-care and surviving emotionally taxing work environments. I've reworked it for now. It's March 2020 at the time of recording this, and our circumstances have changed. So has the presentation. For one, I'm moving it on to YouTube because I'm not sure that we're going to be doing much in the way of face-to-face in services for the next few weeks. And two, our workplace has changed a bit too, hey? So just as a reminder, I'm sure everybody's seen this graph, and by the time you're reading it, the chart might have changed entirely. But as at 24 March 2020, Australia's clocked up over 2,000 notifications of COVID-19. And and I know that some hospitals around the country are probably already feeling the weight of those new notifications. The hospital that I'm working at is in that getting ready kind of phase. It reminds me of how the hospital feels just before a cyclone, very much the calm before the storm. And that's where our hospital is at the moment. But it's still a good idea to start thinking about our self-care and our head health. Now's probably the best time to be thinking about it before all our work comes our way. Now, I don't want to be too pessimistic here, but just recently, just 2 days ago, I think it was 23rd of March, some data came out from Wuhan and other places in regional China, but most of these people were from Wuhan. They're all healthcare workers, mostly nurses, also some physicians and other allied health workers in there. But at the end of their crisis, it's interesting that 50% of people were reporting symptoms of depression, 45% symptoms of anxiety, just over a third were having trouble with sleep, and 72% reported experiencing distress during their crest of the wave of COVID-19 presentations. That sounds more alarming than it probably is. I really want to draw your attention to that they're talking about symptoms of depression. They used those screening tools, which I'm sure you've seen at work, which tick boxes here, and these are common symptoms of depression. Keep in mind they're screening tools, they're not diagnostic tools, so I'm not assuming for a moment that 50% of these people have gone into treatment for depression, or 45% have gone into treatment for anxiety, but a lot of them are reporting a lot of those symptoms. That's what this is saying. Put it in a broader context, a more long-term context. This is a data cut that comes from a paper, Australian paper that was published in 2016, where if you have a quick look at this graph, boys are blue and girls are green, as we can see here. And if you go to the right-hand side of the chart in the first place, and I'll draw your attention to the blue graph there, and then come over from where it's got other occupations, so employed people, and this is talking about something quite alarming. It's talking about suicide rates, but employed males have about the same rate of suicide in male doctors. We'll go to the green ones now. Female people in other jobs have a slightly less suicide rate than females in other health professions. Female doctors have twice the suicide rate of females who aren't working in health, and female nurses and midwives, it's about 3 times the rate. Us male nurses and midwives, our rate of suicide is a fair bit higher than our female colleagues, and also higher than it is for blokes in other jobs. So when we're talking about symptoms of anxiety and depression, we're not talking about them, we're talking about us. We're more vulnerable for people in most jobs. Now, that's the depressing part of this presentation over and done with. Normally I don't lead with all this bad news, but I really want to kind of grab your attention because the rest of the stuff that we're talking about is lighter, but it's kind of important, I reckon, because of those reasons that I've just explained. When we deal with crisis, the first thing we need to do is check in on ourselves, how we're reacting. And look, I think if you're not feeling a bit anxious as at March 2020, you're not paying enough attention. There's a bit going on, hey? There's a saying I heard somebody say years and years ago. They were talking about crash carts in ED, the crash teams in ED, and they said in a slightly wanky way, oh, you know, in the case of an emergency, the first pulse you should take is your own. And I get it. It is slightly wanky, but I guess what I'm thinking about that we can kind of borrow from that too when we're thinking about our anxiety. Before we go rushing in to help somebody else, we want to just check in on our own anxiety and how we're feeling. Are we in the right headspace to be helping others at the moment, or do we need to sort of take a moment and help ourselves? There's a word that you might not have used much since you were writing an essay about mental health in university. It's called countertransference. And just as a reminder, a lot of these words in psychiatry come from 100 or so years ago from famous Austrians like Sigmund Freud. And they spoke about the patient comes in to see me and she seems to have some transference of feelings upon me, and they transfer their feelings from the other part of their life onto me. And me, as the clinician, as the therapist, I can't transfer. I have feelings for them also, and I need to watch out for that does not interfere with my therapy. They said something like that. What they're really talking about is that we need to be mindful that we're not clinical robots. We too have thoughts and feelings, but we're getting paid to do a job, and while we're on the boss's time, while the boss is paying us, we want to just keep an eye out that we're not reacting or responding to other people's distress with our own distress. We want to kind of come to work and impersonate a health professional who's cool, calm and collected, right? That's what I think is a good idea. And it sounds easier. I think it's easier to say than it is to do sometimes. There's this lovely little, very professional diagram which I borrowed from a bloke called Ian Miller. He used to be a nurse educator down in Canberra, and Ian spoke about this circle of care where the care goes in towards the patient, and the next outer ring to the patient are the family and friends, and then there's the other rellies and the other friends, and then it's us, the people at the front line, allied health staff, nurses, doctors, and we are all sending care in towards the patient. And we're allowing room for some crap to come away from the patient. So there's this one direction. The care goes in towards the patient, the crap comes out away. The closer you are, the circle that you're in that's closer to the patient, the more care you're going to need, and the bigger avenue, and you'll still need an avenue for crap to come out. I hope that makes sense. It probably doesn't, but the diagram makes sense. What I'm talking about here is that we need to have some care coming into us as well, and we need some space for some of our crap to come out, and hopefully that will be with our colleagues, but also the broader community. Like, interestingly, just yesterday it was announced that Coles are opening up early for health workers, so if you turn up with your work badge on, you can get in early before everybody else. So hopefully some of us will have some toilet paper in coming days, and that's, I guess, an example of the community care coming our way, which is good. I'll take it. I really need that toilet paper. The other thing that happens when people are in distress is they will act that stress out, and I don't think I'd be doing a very good job doing an education session if I didn't introduce you to a word that you might not have heard before. That's the trick of being an educator. You makes you look cleverer than what you really are. And this word that you might not have heard of is called lalokesia. And lalokesia is from two words in Greek, lalo for language, kesia for, I think it means shit. And anyway, lalokesia, the definition is the emotional release you get through using foul language. And I think in where I work, anyway, a lot of people use lalokesia. They're not necessarily being abusive, but you see it when people are getting stressed. They start saying, you know, bloody this and bastard that, and it goes further. I won't put it down on YouTube, but you know what I'm talking about. And it's important to know, because this isn't a great time for us to be taking a zero tolerance approach to every little niggle that people have. We're all anxious. Not just us, but our patients as well. And there's some silly signs that have been put out over the years. This one I think is the silliest, which is saying getting angry only makes things worse. Getting angry is a perfectly normal human emotion. Getting abusive makes things worse. And what I'm suggesting here for a moment is let's give a little bit of elasticity to people expressing their distress, expressing their anxiety, and let's just give them room for that. Let's not let our countertransference get in the way, but also don't hang ourselves out there to be abused. That's not what we're there for. But I think a good way to frame that so we can be helping other people and still be able to take care of ourselves is just to reframe that no excuse for abuse kind of thing, and just change it. Say, put your hand up and talk to us. We don't want you to feel distress. If you're feeling upset or frustrated or unsure about what's going on, please don't bottle it up. Talk to us. And one of the nurses or the doctors or the other hospital staff, will listen to your concerns. And if we can, we'll try to help you allay that concern. We should be inviting people to tell us how they're feeling, not trying to shut it down. My concern with the zero tolerance idea is that people do feel shut down if they can't express their anxiety or their concerns. Just on that, we don't need to reinvent a model on how to address somebody in crisis. We've got it already from the basic life support model, and that starts with the danger response and send for help thing. And so bringing it back to this idea, what I'm talking about at the moment around emotional stuff, if you're at risk, don't put yourself forward. If you're unable to respond in a way that person reacts to, just get help. It's not inventing anything new. It's okay. You might not be able to handle every crisis by yourself. Let's face it, we're all in this together. People like being asked for help usually, so yeah, there'll be help around. Right, now let me go off on a completely different track for a moment and gather around, children. Uncle Paul's going to tell you a little story. About 100 years ago in Wales, there were miners, coal miners, and they would go down coal mines and they would get filthy and they would trudge home to their miserable little miner's cottage and use their own hot water to wash their clothes and have a bath. And a few of them got together and said, oh, I'm not sure if that's quite right. We get dirty on the boss's time. We really should get cleaned up on the boss's time, hey? And they went back to the mining bosses and told them that. And the mining bosses went, oh, no, we couldn't possibly help you out with hot water and stuff. We'd go broke. And so these Welsh miners went on strike, and they stayed on strike for months and months and months. A few of those mines were closed down for years, I think. Anyway, they stayed on strike for a long time until finally the mining bosses said, all right, we give in. And it was enshrined in mines in the Western world anyway, that if you're working in a mine, you have pit head baths and pit head time. And what that's about is that if you get grubby on the boss's time, you get cleaned up on the boss's time. And that's turned out to be just standard practice for mines all around the world. This will make sense in a minute, don't worry about it. Now, you might remember Todd and the other guy who was stuck down in Beaconsfield. God, I can't remember his name at the moment. But anyway, those Beaconsfield miners who were stuck underground for a fortnight, and they would have been, because they were in really close quarters and under a pile of ruck, so they would have been sharing each other's urine, faeces and sweat and tears and lalakesia for that 2 weeks. But you remember when the newscast came out, the broadcast came out that they were getting released from the mine. They took a long time to get out. That's because they stopped within the mine. They changed clothes. One of them shaved. They both showered and shampooed, changed into clean clothes, and then they checked off of work. They were getting paid all the time there that they were getting cleaned up work. Why am I telling you that? Well, us healthcare workers don't tend to get covered in too much in the way of mining dirt and dust, but we do emotional labour, and we will get covered in the emotional labour of the work that we do. And if we're getting grubby at work on the boss's time, we should think about how are we going to get cleaned up at work on the boss's time too. We don't have to reinvent a model for that. That's been invented for us. It's called clinical supervision. A lady called Bridget Proctor, one of the rock stars of clinical supervision, came up with these 3 primary functions of clinical supervision. She also liked finishing words with ATIVE. But anyway, her 3 functions of clinical supervision are the formative function, and that's about learning as we go, like on-the-job learning, that we're forming new knowledge and skills. The normative, that's about the stuff that keeps us within the codes of practice and codes of conduct and those sorts of things that guide our practice, the policies and procedures. Are we staying within the norms? And the bit that I value the most, the bit that I'm kind of talking about here, is the restorative function of clinical supervision. We do emotional labour, we need to do something with those emotions, and clinical supervision provides that space for that. What is clinical supervision? It's a place where we can sit with a trusted colleague and we can discuss the good and not so good parts about our job and reflect on our job and what learnings we're getting and how it's affecting us and what we can do differently. A lot of people their first reaction is like, we can't afford to spend money on nurses and midwives sitting around talking, thinking and reflecting, but really from the patient safety perspective, we can't afford not to. If we don't intentionally think about our practice, how the hell are we going to improve it? There's a long history of people getting clinical supervision. If you speak to social workers, psychologists in particular, it's kind of built into their job. In mental health, it's been built into our job for a long time for mental health nurses in Queensland since 2009. There's been guidelines which said that we're all entitled to clinical supervision. Not every mental health nurse has taken up clinical supervision, but they're entitled to get it if they want it. And then I'm not sure if you would have seen it, but April 2019, the College of Midwives, College of Nurses and the Australian College of Mental Health Nurses put out a joint statement saying that clinical supervision should be available to all nurses and midwives, no matter what level of experience or what area they're working in. So there's this framework, there's support to have clinical supervision to address your emotional labour and your skill set and how you're going, staying within guidelines, and to do that on the boss's time. Easier said than done, I know, but I think this is a really good time to think about how we're going to support each other. Clinical supervision, nurses and midwives hate that word supervision, I think because we come from a culture of matrons and bullying and blah, 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 that we just kind of bristle at it. I think if you started again, you'd probably call it guided reflective practice. That's what it is. It's not scrutiny, it's support. It's nurturing the people who are nurturing the patients. It's good for us. While we're thinking about that, let's think about the other things that we can do to keep our resilience going in the workplace. Something I do, because I go from patient to patient and ward to ward, I make every hand washing or hand cleaning opportunity a mindful moment. And I stop and I slow down. I get really intentional that just for this moment, I'm going to wash my hands, but not just wash my hands, not for the patient's sake, not for to improve my standing with infection control, but for myself. And I just take it to check in on my breathing, to slow myself down. And because I'm punctuating my day by washing my hands many times a day, I just buy myself that little 30-second, maybe 40, 50, 60-second window in between doing tasks just for myself. And for me, that really works. There's probably other things that people are doing to build in resilience in their workplace. You could ask other people, what tricks do you use to manage your stress as you go? I've heard from other people that they make sure that they bring really good food, or they make sure that they take a break from the ward and get off the ward, or even outside if the weather's okay. But think about, what are you going to do to make yourself more resilient in the workplace each and every day? And give yourself that responsibility in that task. Some of us are going to need a bit of a hand with addressing some of those stresses, and that's fine. If you have a look around on QEPS, the Queensland Health internal website thing, and you might be able to find this thing called "That Was Bloody Stressful, What's Next?" It's about stress reactions, and we all have stress reactions, and this is this resource is just a done 6-page handout, but it's got some ideas about what you might be able to do and what your family and friends might be able to do. Our employer has outsourced the employee assistance program to an external provider, and at the moment that's Benistar, and that's their phone number there. And they can give you confidential support away from the workplace. You don't have to be telling your workmates and stuff that you're struggling if you don't want to. If you want to get confidential support, that's the place to do it. And the other place to do it for us nurses and midwives is via the Nurse and Midwife Support line. That's a 24-hour number. And they've also got some good resources on their website, as you'll see the website down there. So look, do have a look at some of those resources. If you want to have a look at any of the things that I've spoken about here, that web address there, metaphorrn.com/head, I'll put in a link to all these resources that I've spoken about. Thanks for listening. Good luck over the next few months. It'll be a big deal, and all the best.